this afternoon is something very exciting in the area of biometry. A device you may not have seen yet, or you may have seen it on the floor. It's called the Eyestar. And it's a completely new concept with biometry, and I'm going to share some thoughts with you about how it's used and how we've used it. And many of the patients I'm going to show are my own patients, and with some very, very challenging situations. Ours is a referral practice. A lot of what we do is for other ophthalmologists, and of course nobody's going to send us a normal patient. So it's a chance to test the limits of biometry and what can happen to the human eye. So basically it's a complete reimagination of biometry. It's not just a biometer where we measure the axial length and keratometry. It's three devices at the same time. And for those who are anterior segment surgeons, these are the must-have devices and instrumentation that you need to do what we do in anterior segment surgery. So it basically takes the place of a whole room full of equipment in this little tiny box. It's this big by this big. And it may seem as though it's a little expensive, but if you look at the cost of the three different devices, a world-class topographer, anterior segment OCT, and a biometer, it actually turns out to be something of a bargain. And all the measurements are very sophisticated. So think about everything that comes from Haag-Streit. Have you ever seen anything from Haag-Streit that wasn't perfect? And this is an example of that. So there's no compromises in this whatsoever. One of the most exciting things is validation criteria. You remember maybe about 10 years ago we started using those little cards that would sit next to the biometer, and we would validate the Ks and the axial measurements. Well, this all runs automatically now behind the curtain. So every single measurement, if it has a little check mark next to it, it means that multiple measurements have been done and they all meet validation criteria. So one of the more exciting things is it's completely automatic. So you put the patient in front, it does both eyes in 40 seconds, all the measurements. So the least experienced technician in your office or the most experienced technician get the exact same quality of measurements. And again, everything's fully automated. So let's go through some of the different parts of it, and I'll show you why I'm so excited about this. Everything's done with swept source OCT, except portions of the Ks are also a combination of swept source OCT and reflective keratometry. The way things are presented is the way you're used to seeing them. So the axial measurements are in a familiar format like an immersion A scan, and then we have very high resolution scans. And the method by which the scans are made is something you may never have seen before. With swept source OCT, you're usually used to single radial measurements kind of marching along the front part of the eye. This uses a scanning technique that's new to ophthalmology, and it allows for a density of measurements that's many, many times higher than anything you've seen before. It generates a type A corneal map, so those of you who are familiar with, say, the Zeiss Atlas topographer, which is the industry standard, this looks very much like that. It directly measures the anterior and the posterior cornea. So unlike some machines that measure the anterior cornea and regional pachymetry and then extrapolate the posterior cornea, this actually does direct measurements of the posterior cornea, and it has regional pachymetry. And the measurements go all the way to the limbus, so it's not an 8 or 9 millimeter diameter. It's the full diameter of the cornea all the way to the limbus. It does a Zernike analysis, which is, you might know that as just a wavefront analysis. I'm going to show you some ways that we use this for a conversation with the patients to see if they're a multifocal candidate. We use it for multifocal screening. And also if somebody comes to you and they're unhappy with your vision, the majority of the time this may be the reason for that, other than a decentered IOL or cystoid macular edema, things like that. It does image simulation that very much approximates what the patient sees. So some devices very strongly overstate the image simulation. When we show this to a patient, they say, yes, that's exactly how I see in that situation. So you can use it for two things. One is to predict how they will see, and the other is to confirm the patient's symptoms if they come to you and they're unhappy with their vision. you can show that to them. And it has zone-based keratometry, which we've all used for toric IOLs. Now this is the exciting part. This is called Mandala scanning. So instead of just a radial scan that marches slowly across the cornea, this is almost a type of scanning with infinite density. So this is what we're used to seeing with OCT, and here's a Mandala scan. And so you can see how we can increase the density, and every single one of those circles is one set of measurements. And we do it over and over and over again. And it can be used with a few different tools, one of which is we can combine the measurements and make a very high density, high quality measurement by stitching everything together. All of our patients will have little saccades of the eyes when we do the measurements, and this can be used to account for motion compensation. And again, it's also used to produce very high density, very high quality images. So we scan, and again, every one of those little circles with Mandela scan, that's a whole image. And then we scan again and again and again and again, and we get these incredibly high density measurements. So these are some examples of motion compensation. There's always going to be some little tiny saccades of the eye when we do these. A device where that is more of an issue would be something like shine fluke photography, where it takes 2 seconds for the shine fluke camera to go all the way around the eye. This completely eliminates any motion artifacts. So the image on the left is just with a regular Mandela scan. The image on the right is with a higher density Mandela scan. You can see the difference in the quality of the image and also the information that it returns. So just another look at motion compensation. So here's one image, here's another, and this is just 7 scans. And with the Mandela scan, it can do hundreds of scans. So this is why the images are so beautiful and such high resolution, is because it's adding together all these different measurements. Now for the axial measurements, it looks just like we're used to seeing with an immersion A scan. We have the anterior cornea, the posterior cornea, anterior lens capsule, fine detail of the lens, the cortex nucleus junction, the nucleus, the cortex nucleus junction, and then the posterior cornea, the vitreous cavity, and then the internal limiting membrane and the RPE. Right now, the distance between the RPE and the ILM is fixed at 200 microns, but the measurement is from the corneal vertex to the RPE. Let's go back here. Okay, and you can visualize where the gates are setting. So you have a high-resolution B scan, and if for some reason the computer puts the gate in the wrong place, all you have to do is move the gate exactly where it needs to be. So for some complex cataracts, it can be a little difficult. But again, it's in the format of an immersion A scan that we're all used to looking at. And we get these little caution triangles. So this is an 18-millimeter eye, and certainly not normal, and the machine is saying, you know, better pay attention to both how shallow the anterior chamber is and the axial length. Now you only need about 1.5 millimeters of a pupil to do a perfectly normal scan. This is somebody with a Chimera implant. So we've got 1.6 millimeters, that's the aperture. We can get a completely normal high-resolution scan through 1.6 millimeters. So if you have a patient on chronic pilocarpine therapy, say with a pupillary membrane, it's not a problem with this. It works very nicely. So that's 1.6 millimeters. So let me show you some of my own patients. Again, ours is a referral practice. We see some crazy stuff from all around the United States. One of the questions that always comes up with a new biometer is, what is the dense cataract penetration? That's what everybody wants to know. And I'm going to show that to you. So here's a 38-year-old woman who had a prior retinal detachment with a vitrectomy, some early diabetic eye disease, and developed a post-vitrectomy cataract, a big, dense PSC plaque. She has hand movements vision. And with the Iowa we get nothing, not a single return from the retina. And with the Eyestar, we don't get any useful measurements. In fact, if you look at the histogram with the Eyestar, even in the dense cataract mode, what we get is an unusable little peak, and we get the diagnostic returned from the LenStar that, we can't use this, so it's not useful. This is with the Eyestar. Now the right eye is normal, and so you can see the posterior capsule looks just like it does for any patient. And there's the posterior capsule area for this, and it has a big, dense PSC plaque. So even though the signal that's returned has a low amplitude, it's still normal. And the device will run validation criteria in the background and tell you if you can use this. So let's look at the measurement summary page, and you can see that you can see the little check marks next to keratometry and the other measurements, and that means that these measurements are valid. So it was 22.07, the patient's in axial hyperope, and so this was kind of early on when we were trialing the Eyestar, and when we have a cataract that's that dense, I always do an immersion A scan myself. I don't have my staff do it, I do it myself. So here's the immersion A scan, and it's 22.07. So, I was convinced that this thing can really get through a lot of very, very dense cataracts. Now, one of the most wonderful things about the biometers from Haag-Streit is the keratometry. And you probably remember when the LenStar first came out, the aspect of it that was really exciting was the keratometry. There were 2 rings, 32 measurements at 1.65 and 2.3 millimeters. And this completely transformed toric IOL use for certainly us in North America. The device has 32 measurement points, but you notice they interdigitate. So instead of the 2 rings being along the same meridian, now they're canted. So instead of being 22 degrees, it's 11 degrees. So it doubled the density of the measurement. So there's less iteration, and it's more likely to have a measurement point correspond with the exact steep meridian of the patient. Actually, let's go back here just a minute. Now you can see this, we get a video keratographic image, so you can see the quality of the LED displays in real time. So if they're smeared or if they're missing because of an unstable ocular surface, you can tell that, and then you would delete and you would repeat the measurements. So this would be the video keratographic image for this eye that also has topography. So again, the Ks are really one of the strongest features of this, and a lot of time was put into this by the R&D team at Haag-Streit in the keratometry. For those of us who develop IOL power calculation methods, the keratometry probably has the greatest amount of mathematical noise and is one of the highest sources of error for IOL power calculations. So when people ask me, what biometer should I get, look at all of them and see which one has the best Ks, because that's where it's going to be important. In fact, in our practice, we optimize the ocular surface prior to biometry. We do it for 2 weeks. If in an extreme situation, we may only do it for 1 week, but if the patient refuses to optimize the ocular surface, we tell them you need another doctor, because it's that important. So we do lid scrubs twice a day, not lid scrubs, rather warm compresses. And what the warm compresses do is they release the lipid-rich meibomian gland secretions, which play a major role in stabilizing the ocular surface. That's followed by lid scrubs and then frequent high-quality artificial tears. So the keratometry is just such an important part of our IOL power calculations. The optics are telocentric, which means if the patient's a little bit forward or a little bit backwards, the measurement's still going to be correct. And then the Ks duplicate what you would get with the LenStar, so you don't have to re-optimize your lens constants. They're the same numbers, but they're more robust, and that's the key here. And you can do keratometry on patients with this that you couldn't before, and I'm going to show you some examples of that. So as I mentioned, it's 32 measurement points, but instead of the points for each ring being in the same meridian, now they're canted, so it goes from 22 to 11 degrees apart. Everything's centered on the visual axis, very robust keratometry, and only 1 measurement is required for all of these multiple measurements to be done. So let's just review some technology, and I'll show you how keratometry is done, and you'll see why this is so important. This is the Eyestar 500 And earlier, it's 6 measurement points, 3 above, 3 below the horizontal meridian, and they're separated by 60 degrees. So what happens if the steep meridian's at 90 degrees? It's not a direct measurement at 90 degrees, is it? It's a measurement at 60 and 120, and it extrapolates that. Here's the Eyestar 700. It's 3 rings. Each of the points within the 3 rings is separated by 60 degrees, but next to each other they're 30 degrees. So it does improve the measurement density, but it's still only 18 measurement points. This is the LensStar, which kind of started this whole thing, about 15 years ago. And you can see we have a higher density of measurements. It's 32 measurement points. It's 22.5 degrees apart. And this is the Eyestar, again 32 measurement points, but they're now more closely spaced. So it's now 11.25 degrees. Very high density measurements. And this makes a huge difference when it comes to the accuracy for the toric IOL. So here's some examples of some of our patients. The old joke we like to tell is that we live in the keratorefractive Wild West in the southwestern United States, where if you can do it to a human eye, some of the people in our area have done it. We see a lot of patients with radial keratotomy. I'm not sure here in the Middle East if RK was very popular, but where we live, they did a lot of keratometry, radial keratotomy. So here's Eyestar like 500 and earlier. We get nothing, okay? And even on the LensStar, we get nothing. We can't measure it at all. This is with the Eyestar. We get a topographic axial curvature map, we get Ks, and we get validated Ks. This is a patient that not even the LensStar could measure it. And you get diagnostic feedback. Tells us the gold strand ratio is elevated, and we have an unstable ocular surface. What a difference. I mean, this is, talk about robust Ks. This patient had 10 or 11 diopters of corneal astigmatism. So this is really our go-to machine for the unusual eyes. So you get a live video keratographic image. You can see the quality of the LED reflected light. You get reflective keratometry. Believe it or not, that's still the standard that we use when we develop intraocular lens power calculations. And you get a type A topographic map. This is an axial curvature map. So pretty much everything that you need for the toric IOL. And the main questions we ask is the astigmatism regular, which means we can draw a line through the corneal vertex in the center of the 2 astigmatic lobes? Is the corneal astigmatism symmetrical? We have similar power on either side of the corneal vertex. What's the steep meridian? Again, that line through the corneal vertex and the 2 astigmatic lobes. And then do we have validated Ks? So pretty much everything you need for very, very accurate toric IOL implantation is right here in this one device. And the measurements are validated. They're internally validated. You don't need to have that little card next to the device to see if the measurements are okay. Now for the toric IOL, we have several different ways of measurement. We have the Barrett formula, both a posterior corneal mathematical model and then a direct measurement of the posterior cornea. And then we also have artificial intelligence toric IOL calculations, the Abulafia-Koch algorithm, and then my formula, Hill RPF. So pretty much every calculation method that you need, plus some that aren't even on some of the other biometers we have here. So this is the must-have device for toric IOLs. And for those of you who don't have alignment software on your surgical microscope or incorporated into the femtosecond laser, it generates a white light image that gives you the displayed image of the toric IOL, the steep meridian, the flat meridian, the calculated meridian of implantation. You can take this printed out, put it upside down on the surgical microscope head, and then use this, including the alignment meridian at 180 degrees. Use this for your toric IOL. It even shows the incision location, which you pre-plan in the instrument. Okay, so let's talk about some of the discussions we have with patients. As I mentioned several times, ours is a referral practice. People come from all over the United States to see us for different things, and they don't travel all that way just to have a technician do a couple of measurements and then tell them to wait in the waiting room. I spend time with them. I spend about 40 minutes with them, and I go through the measurements with them. I'm going to show you how we do the discussion with this. First of all, these are the 4 basic topographic maps that the device will give. It's exactly the same as the best topographer in your practice. You have an axial curvature map, anterior elevation map, a toric elevation map, and then the tangential map. So this is what most people use. This is the axial curvature map, which most of us are familiar with, and it's used a lot for toric IOL planning. The axial curvature map assumes that most of the rays of light pass through the central cornea. And for the toric IOL, that makes sense because we're looking mostly at the central cornea. And again, we can use it to make sure that the astigmatism is regular, it's symmetrical, and the orientation of the steep meridian. So this is very useful for the toric. This is a tangential map, and those of you who deal with keratoconus might use this a lot. This is a little bit more accurate for the interface for different power changes. The image looks a little bit smaller on all topographers for a tangential map. One of the advantages of a tangential map is that it doesn't make any assumptions about how the rays of light pass through the cornea, so I think it's a little bit more accurate and has a little less data smoothing. It's not quite as familiar to most people, but if you deal a lot with keratoconus, this is the map that a lot of people use. So let's go through the discussions that we have. Remember, when you have refractive surgery, especially things like radial keratotomy or early generation ablative procedures like 8 diopters of myopic LASIK from the late 90s, you're going to generate high order aberrations. And these are the people who are coming to cataract surgery right now. And all an aberration does is something that reduces image contrast. And we can show patients how they're going to see after surgery. And this is really helpful. So here's an example of one of the countless patients that we see in our practice for other physicians. This is somebody that's had a myopic ablation. This is an 8 diopter early generation myopic ablation. And you can see we have a flattened central cornea, and the greatest zone of flattening is decentered. So with flattening of the central cornea, we're going to generate spherical aberration. And with decentration, we're going to generate coma. Coma is a form of irregular astigmatism and a killer of multifocal lenses. You do not put multifocal lenses in these patients that have elevated coma. And this can also be a screening device. If you're not sure if Mrs. Jones would do well with a multifocal lens, you get an aberration profile, and if they have elevated coma, this person is just not a candidate. And I really firmly believe that this should be part of the screening protocol for every multifocal lens. So this person has a flattened central cornea, and they also have changes in power in the intermediate and marginal areas. That's not as important for what we're doing as what goes on with the central cornea. So this is what happens with spherical aberration. You get the characteristic halo and glow of the image, and there would be the big EI in the eye chart. You can see the glow around it. And then we get coma, which is a form of irregular astigmatism. So horizontal coma means you have more power to the right or the left of the corneal vertex, and then vertical coma means you have more power above or below the corneal vertex, and it's highly asymmetric, and that produces an aberration called coma, and coma produces image displacement and duplication. So you've probably heard some of your LASIK patients say, well, if I cover one eye and I look at the full moon at night, I see 2 images. They're describing coma, that's what they're describing to you. And with the early generations of ablative surgery and also radial keratotomy, this is what the patients see at larger pupil sizes. And speaking of pupil sizes, you can show people how they will see at different pupil sizes. So here's somebody with a toric IOL, and we can show them what their uncorrected vision would be with a spherical IOL. So this would be photopic vision during the day, mesopic vision around dusk, and then scotopic vision at night. And all aberrations are radius dependent, which means as the pupil gets bigger, the aberrations have a greater effect. And you can show them what their vision is going to be like. Here's somebody with myopic LASIK, and we can show them how they would benefit from scleral contact lens, because there isn't an intraocular lens solution for something like that. So this is daytime vision, vision around dusk, and then vision at night. And so we're actually showing people how they're going to see, after surgery. And this is very, very closely tied to their actual vision. It doesn't overstate the case. This is somebody with hyperopic LASIK, scotopic, smaller vision, mesopic around dusk, and then, rather scotopic is large people, this would be photopic in the beginning, and then here is scotopic vision at night. And then this is the case for a scleral contact lens. Again, there's no intraocular lens solution for something like this, and this is our nemesis radiokeratotomy. So this would be during the day, this would be around dusk, and this would be at night. Again, all aberrations are radius dependent, so the larger the pupil, the more impact the aberration has. Now, we have, there's something called the AC suite, the anterior chamber suite, and with OCT we can get these wonderful topographic images, and we also get OCT imaging of the front part of the eye out to 18 millimeters, and I'll show you some of those. Here in the Middle East, keratoconus is a really big problem. And if you're trying to tell the difference between just straight up keratoconus and say something like pellucid marginal degeneration, you need to image the inferior cornea all the way to the limbus. So for PMD, you get that clear zone, 1 or 2 millimeters from the inferior limbus, and then the steepening areas out at 4 and 8 o'clock. Well, this will image all of those. And a lot of times we get sent patients with the diagnosis of keratoconus, and they don't have keratoconus, or they have a diagnosis of PMD, and they've never had that. What they have is perhaps a variation on keratoconus. So with the right kind of imaging, you can see all the way out to the limbus, and you can make the correct diagnosis. And I think I've only seen one PMD patient, maybe 2 in 40 years. Most of them are just plain keratoconus like this. It's a keratoconus patient. It's not pellucid marginal degeneration. So we get imaging all the way out to the limbus. Okay, and let's take a look what I've got here. Yeah, the other thing is if you see a lot of keratoconus patients, one of the things you do is you have to follow them over time. And we can't go through every variation, but there's trend analysis maps, and you can create maps for following these patients in any format that you want. And you can set this up in the way that you're most comfortable with, so you can track the progression of the disease over time. One thing this doesn't have at the moment, but it will have in the near future, is epithelial mapping. And this allows us to diagnose keratoconus in childhood. And with the right approach, we can, you can stabilize these corneas and save a lot of these patients, a lifetime of problems. But you can make the diagnosis early. Right now, we do the 4 basic criteria for keratoconus: focal steepening, focal thinning, apex displacement, and ectasia. Has a lovely ectasia section, and then we'll have epithelial mapping as well. So this is the ectasia area, and it looks very familiar. It looks a little bit like the Pentacam, doesn't it? Where you can see the pachymetry, the progression of the chemistry, and make the diagnosis of true ectasia. It also has Michael Baidlin's ABCD grading system, and you can have that for each one of your individual studies at each patient visit. And then lastly, let's talk about the OCT imaging of the anterior segment. I have a glaucoma specialist in my practice, and we use this for very nicely for angle measurements. So, as you know, if you're 15 to 10 degrees, we think about doing something. If you're 10 degrees or below, we start scheduling surgery, right away. So we can actually measure the angles and can do it objectively. This is somebody that has kind of an interesting feature of asymmetric angles. So nasally and temporally, the angles are different. On one side, the angle can be occluded. On the other side, not so much. We can actually have objective measurements with this. So let's say somebody's 20 and 16, and then we bring them back in 4 months, and they're 18 and 12. We know that we need to think about doing something. We've stopped doing PIs, and we've started recommending cataract surgery because I think that's the definitive treatment for narrow angles, especially in high hyperopes. And this is the quality of some of the images. So this is somebody that's had a penetrating keratoplasty, somebody with intacts. You can see the grooves or the channels for the intacts. Here's somebody with pseudophakic bullous keratopathy, and then after DMEC. We do a fair amount of DMEC in our practice. It's pretty much everything we need as anterior segment surgeons in a single box, and it takes the place of a whole room full of equipment. So it's all the must-have stuff that we need to do. And as you can imagine from Haag-Streit, there are never any compromises. Think of the last thing you ever saw from Haag-Streit that wasn't perfect. It just doesn't happen. And this device is a good example of that. The measurements are completed in 40 seconds for both eyes. So imagine the throughput in your office. And also the measurements are internally validated. So as far as workflow goes, this can be a real boon for your practice and make things, a lot easier and a lot more consistent. And again, technicians with different levels of experience all get the exact same outcomes. And then behind the curtain, running invisibly, are all the validation criteria. And Haag-Streit has spent a lot of time making sure that when you get that little check mark next to a measurement, it's correct. And so you don't need to sit and worry about, are the measurements valid? So basically, what's the whole point of all this? Well, confidence for us as physicians, and then of course, happy patients. And in our practice, we have two clients. We have the referring physician and we have the patient. When we do the surgery, we need to keep both happy. So everybody's happy when we use this device, and we're just delighted that Haag-Streit has taken the many years it requires to develop something like this that's not only of the highest quality, but also contains a lot of innovations like Mandala scanning, like internal validation. That's pretty much unique and individual in ophthalmology. Other companies just don't have this, and it's exactly what you'd expect from an old and trusted friend like Haag-Streit. Thank you.